السلام عليكم ورحمة الله وبركاته. أنا وائل جعفر الأمين، كلية طب، أو خريج كلية طب الدفعة الثانية جامعة الرباط الوطني. شكرا لكم كثير على الشباب والشابات الحاضرين اليوم معنا اللايف ديت، وكل الناس اللي أخذوا من زمنهم ساعة وأقل إن شاء الله عشان يحضروا فيها اللايف ديت. لي الشرف الكبير في الانتماء للمكتب الأكاديمي لتجمع خريجي كلية طب جامعة الرباط الوطني. المكان اللي أخذنا منه كثير وتعلمنا منه كثير وبنينا فيه الأساس، ومنه الحمد لله مشينا لقدام. لازم أخذ الثاني حاجة عشان أشكر الشباب القائمين على موضوع المكتب الأكاديمي، والشباب المنسقين للمجموعة أو السلسلة بتاعت المحاضرات التوعوية ب كوفيد 19 فيروس، وبالأخص محمد حسن ضفع الله وأحمد مأمون، كتر خيرهم كثير، الله يديم العافية وإن شاء الله في ميزان حسناتهم. المحاضرة دي حتختلف إن شاء الله عن مثيلاتها من المحاضرات السابقة أو البرزنتيشن السابقة. الغرض في الموضوع إنه الشباب زملائي اللي قدموا المحاضرات اللي فاتت الله يديهم العافية، عملوا مجهود جبار جدا وشغل جميل جدا جدا في إنه هم وضحوا كل حاجة فيما يخص الباثولوجي بتاع الفيروس نفسه، والباك جراوند بتاع الفيروس، والشغل بتاع المولكيولر بيولوجي بتاعه. فأم not going to go into this point. ما حنعيد الكلام، ما شاء الله شباب ما بيحتاج أصلا يتعاد بعدهم حاجة، حتى up to دكتورة آيات الجاينيكولوجيست زميلتنا البرزنتيشن بتاعها كان جميل جدا امبارح يعني. الهدف من المحاضرة ديت هو مناقشة حالة ممكن تمر على أي شخص موجود في الطوارئ، موجود في casualty، موجود في hot area, accidental emergency, ER, you name it the way you name it. It's very common اللي هي حالة الرينال كوليك، ولكن we are going to tackle الحالة from a different perspective a little bit، اللي هو من البوينت حقت COVID-19 which is happening right now in the world يعني. it may not add كثير، لكن الغرض من الدسكشن بتاع الحالة هو إثراء المعلومات. الهدف من المحاضرة توعية زملائنا الخريجين الجداد من الجامعة. مبروك التخريج وبالتوفيق في حياتكم العملية. آمل إن المحاضرة دي تكون إضافة لكم في إنه تمانج عيان الرينال كوليك بطريقة كويسة. نواب الأخصائيين في تخصصات المسالك البولية، جراحة المسالك البولية، أو طب الطوارئ، أو حتى أطباء الطوارئ المناوبين الموجودين هناك الله يديهم العافية. يعني we know very well إنه الظروف اللي هم شغالين فيها في السودان لا يحسدوا عليها. إن شاء الله ربنا يحفظكم يعني ربنا يديكم العافية. أتمنى المحاضرة دي تكون تضيف لكم حاجة تستفيدوا منها. بدون تأخير تاني لأن أوريدي تأخرنا كتير، أنا I will go forward في المحاضرة. بسم الله الرحمن الرحيم. It's an educational case presentation about acute renal colic in the time of COVID-19. Technically speaking, the setup of the presentation was supposed to be in a way that it's a discussion or a dialogue. So you will notice as we go forward in the presentation that I do ask questions and I answer them. طريقة ممتازة ممكن تستفيد منها. I can give some poses. فكر في إجابة للسؤال اللي بطرحه أو الكلام اللي بنقوله، and later on أنا لما أديك الإجابة شوف how far إجابتك اللي أنت قلتها صحيحة أو ما صحيحة يعني. So the points of the presentation are going to be a clinical presentation of the patient, history and examination, blood investigations, radiological investigations, management of this patient, renal colic and COVID-19, and finally a take-home message. Right. So the presenting complaint for our patient, he's a 63-year-old male patient, presented complaining of left lower abdominal pain for the past 12 hours and feeling unwell for the past 4 days. Now in each slide, we are going to talk about this patient, but we are going to dissect every piece of information mentioned in each slide to get the maximum amount of information so that we can appropriately handle this patient. So we have a 63-year-old male patient, left lower abdominal pain for the past 12 hours. Now, with the renal colic patients, it tends to be an acute presentation, so it fits the 12 hours period of time. But our patient also has been feeling unwell for the past 4 days, which is something we need to bear in mind very well as we are dealing with patients in the time of COVID-19. So next slide is going to be the history of presenting illness. And in the history of presenting illness, the patient describes the pain as aching colicky in nature. And now almost all renal colic patients, the way they present with their pain is colicky in nature. اللي هو الشكل بتاع المغص اللي هو it goes and comes لكن it rarely settles. It's almost always there. Located in the left lower abdomen, and it radiates to the testis and upper thigh, as we said, occurring on and off throughout, reaching an intensity of 9 out of 10 in severity. Now, إذا لاحظتوا هنا the patient described the radiation of the pain to the left testis and the upper thigh, and the reason behind this is the shared nerve origin of the nerve supply between the ureter, upper thigh, and the testis, and the vice versa is correct as well. In patients they present with acute testicular pain tends to radiate upward towards the area of the ureter, so it works both ways. So this is a very good way kind of to differentiate between whether the origin of the pain is from the ureter or from the testis. You need to bear in mind something very important. This is not specific for renal colic. It can be with other acute abdominal conditions as well. But let's say roughly that the majority of renal colic patient describes this type of referred pain. Now, he reports no cough but mild fever prior to the presentation. However, the abdominal discomfort has been gradually worsening. الغرض من العبارة اللي أنا خطيتها دي هنا في history of presenting illness, the fact that he doesn't have cough does not mean that he is not a COVID-19 patient. He also describes mild fever prior to the presentation. So this is something, again, when you are dealing with such a patient, you need to bear this in mind. Next slide. The patient as well described increased urinary frequency without visible hematuria, which is something very important. Again, we are going to talk about the hematuria in a minute. He also he has not noticed aggravating factors, but he noticed some relief with the use of ibuprofen. Again, in our presentation, we are going to talk of the role of non-steroidal anti-inflammatory medications in tackling pain of renal colic patient. Apart from associated nausea, he does not endorse other GI complaints, and he has normal bowel habits. Finally, he denies any recent travel or exposure to food outside from home. Now, at this point, I'm going to talk about something very important. Statistically, it has been documented that 50% of patients presenting to accident and emergency with pain that looks typical of a renal colic pain is not actually renal colic patients. So we have a patient who described mild fever or feeling unwell, and he is presenting to accident and emergency with a renal colic sort of type pain. Does not need necessarily to be renal colic. Now, in our patient, it is renal colic, but we are talking about COVID-19 as well. Unfortunately, here in the UK, it has been documented that patient presented with the same presentation diagnosed as طبعا في بداية فترة COVID-19 diagnosed as renal colic has been transferred from the accident and emergency to the urology department, and then later on CT scan showed that the patient has no stones whatsoever, and unfortunately it was just COVID-19, and the whole team had to go into isolation. So this is something really important you need to bear in mind. Next slide. Next, that the patient mentioned a very important key point. للأسف طبعا أهلنا في السودان الله يديهم العافية عندهم very common practice إنه هم يمشوا للمختبر براهم يطلبوا فحوصات براهم، بالذات كمان لو بيعرفوا زول في المختبر أو عندهم قريبهم شغال في المختبر، وبعدين لو طلعوا بنتيجة من الفحوصات دي في الصيدلية بيجيبوا العلاجات مباشرة. That's why I mentioned this هنا في البرزنتيشن ده. We need to be really precise while taking history from the patient. طبعا I won't say دي غلطة المريض طبعا بأي حال من الأحوال، ولا بقول غلطة طبيب المختبر اللي عمل له الفحوصات براه، ولا غلطة الصيدلي اللي أبداه. It's a system problem, so we need to tackle it as a system problem. أنا هنا ما بعيب على أي شخص من الأشخاص اللي ساعدوا الزول ده في البيهيفير ده، ولكن نأمل عسى ولعل إن شاء الله as things إن شاء الله في بلدنا ماشية لأفضل ولإنفراج we can tackle السيستم issues ديت أو systems issues. So 3 days ago, the patient contacted his relative who works as a laboratory technician. The patient relative performed a urine analysis and a malaria serology. Please ركزوا في حتة إنه عمل urine analysis 3 days ago, which both came back to be negative. ما عنده malaria serology is negative, while urine analysis is negative as well. In spite of that, he took a course of artesunate based on the advice of his relative without resolution of his symptoms. So as we go further down in our presentation, we can go quickly through some medical information as well. So his past medical history and surgical history are consistent of psoriatic arthritis and obesity. Of his BMI is 38. His family history is non-contributory, and social history, he's a non-smoker, he's a retired man, does not exercise regularly, of course, hence his BMI is 38, and finally his home medications are methotrexate 10 milligram PO weekly, and as needed ibuprofen for joint pain. No يا علاء، أنا شفت الكومنت هسه الآن حاليا. No, his test came back negative. He does not have malaria. ولكن in spite of this he was advised based on الشخص اللي في المختبر بأنه أخذ the course of artesunate، ما خسران حاجة. لكن no, his test came negative. The patient relayed this as a positive finding، إنه positively الحمد لله أنا فحصت الملاريا وما كان فيها حاجة، وأنا فحصت البول برضو والبول برضو ما كان فيه حاجة. So this to answer your question يا علاء. Okay, we reached now the physical examination. طبعا السيت اب definitely مختلف من بلد للتانية. أنا هنا مثلا when you reach a point إنك عايز تشوف patient that time أنت بتكون already أخذت النوتس حقت البيشنت، عارف الفيتالز حقته عاملة كيف. clearly من الفيتالز دي هنا إحنا شايفين patient التمبريتشر بتاعته 37.8. So we are dealing with a patient of abdominal pain and temperature. Now we go back to the COVID-19. At this point, I will urge my colleagues, please use whatever available PPEs before examining this patient. Don't take it for granted, as this is renal colic. COVID-19 has been documented that it does present in a similar way of presentation. امبارح دكتور آيات قالت كلمة جميلة في البرزنتيشن بتاعها إنه be selfish about موضوع البي بي إيز قبل ما تشوف البيشنت. Now, I do agree معاها 100%, and I can add to this point تانية. أنت you are not just being selfish towards yourself. أنت you are taking care of a whole community. يعني لا سمح الله لو واحد قاعد في الطوارئ وشاف المريض ده وكان COVID-19 and it's positive and he had to go for self-isolation, think of إنه التيم بتاعك بتاع الطوارئ is going to be lacking one doctor at this incident. In 2-3 more incidents زي دي you will end up with no team في الطوارئ يشوف العيانين بتاع الحاجات التانية. الحياة ما واقفة على الكوفيد 19 بس، في ناس تانيين محتاجين برضو emergency service. فأنت you are not just being selfish at this point. No, you are being vigilant. You are being a good practicing doctor by protecting yourself in order to protect the community. So please, at this point, ما تقولوا ده renal colic. Take all PPE measure that available in your department. So the patient appears distressed and restless, which fits adrenal colic, from pain, and he's holding his left flank. His vital signs: blood pressure is 152/87, heart rate is 98, respiratory rate is 21, temperature 37.8, oxygen saturation is 93 at room air, and his pain score is 9 out of 10. Now we have a patient with abdominal pain, mild fever, temperature بتاعته 37.8 and a bit of a low oxygen saturation. I would expect from a man with no prior chest problems like COPD مثلا to have a better oxygen saturation. Now we can always argue that he is in pain, so he is not breathing normally. That's why it is reducing the oxygen saturation. I would say this is right, but not in the time of COVID-19. Bear in mind that this could be COVID-19. Now, at this point, the nurse or the medical assistant or the medical student helping you, he did hand you a urine dip test analysis, thankfully. And we are going to talk a bit more about urine dip test في نفس البرزنتيشن ده. But roughly it shows that white cell count of 2 crosses, red blood cell counts of 2 crosses as well, red blood cells, nitrite, 1 cross, and negative for protein. Next slide. Yes. Now, at this point, it is really important to ask ourselves, how accurate is the dip test? How accurate? So, the dip test is 95% accurate in day 1, 85% accurate in day 2, and accuracy goes down into 65% in day 2. In last day or day 3. هنا في 3 missed من اللاين المكتوب. It is a very good test actually. It's more or less, I would say, reliable, to be honest and to be fair and frank يعني. لكن it depends on the presentation of the patient. Now there are 2 things we need to bear in mind. There is sensitivity and specificity. So the sensitivity of the dip test is quite high actually. It's even, to be honest, better than the urine microscopy, and I'm going to tell why in a minute. But before that, we need to know that the false negative dip test can be found in about 10 to 30% with actual renal colic. So the fact إنه مريضك الديب تيست حقه نيجاتيف does not exclude renal colic. يعني ما تفكرين والله ما في داعي أنا to go forward في الانفستيجيشنز لأنه البيشنت ده أصلا ما عنده يورين، ما عنده blood في اليورين, which is a very common wrong practice that I have seen, to be honest. حتى هنا كثير جدا بيقول لنا ما فكرنا في renal colic ما اليورين تيست ديب تيست بتاعه كان نيجاتيف, and it's a very sensitive test. Yes, it is very sensitive, لكن up to 30% can present without microscopic hematuria. Something also important is that when we compare a urine dip test the urine microscopy, it's slightly sensitivity is higher with the urine dip test because of the nature of the test, the way how the test is being done. Okay, so the microscopic hematuria, the urine microscopy can only detect cells in the urine, so it can be only visualized, and if urine stayed in a bottle for some time, the cells tend to lyse. The laboratory technician will not see any cells, so he's going to give you a false negative. While with the urine dip test, it is highly better in sensitivity about this. So again, a a piece of information: microhematuria can be non-specific despite full urology workup, and it has been reported in up to 70% of patients بيكون عندهم microscopic hematuria, and you exhaust all the urological investigations, but you end up with no urological abnormalities whatsoever. All what you need to do is to reassure them. Next slide. So at this point, you are examining the patient wearing your full PPE. His abdomen is obese without visible scars. Bowel sounds are normal. There is mild tenderness to palpation on the left lower abdomen quadrant without guarding or rebound tenderness. No enlarged organ or masses were felt. Other exam findings are normal, including chest, cardiac, and extremity examination. Something really important at this point in a patient who is in his 60s to examine the patient's aorta. AAA has been also presenting to A&E as leaking AAA طبعا has been presented to A&E as sudden onset of a severe loin colic pain or loin pain, and the patient has been admitted as a renal colic patient while they were actually having a leak in AAA. That's why abdominal examination is really important. Some might say, well, he's a renal colic patient. I've quickly felt his tummy and everything looks fine to me. No. You need to do this with consideration into what age group you are doing that. إذا جاني واحد عمره 25 سنة, yes, I can just feel his tummy roughly or quickly. لكن إذا عندي patient 64-year-old, no, I have to examine his abdomen really well. Another important point is in female patient pregnancy test or other gynecological conditions that can present or mimic renal colic patient. So you need to bear this in mind, especially in childbearing age ladies. Now we come to the point of DRE, digital rectal examination. Digital rectal examination is something really important in completing your urological examination. Now in this patient here, we are suspecting renal stone. So the digital rectal examination may not be of great value, but since take it as a principle in life. Whenever you find a patient with hematuria, macro or microhematuria زي حالة مريضنا ده هنا, you need to do digital rectal examination. But can we do digital rectal examination in a patient in this setup in the time of COVID-19? Now the instructions of the British Urological BAUS, British Association of Urological Surgeons, state clearly that no, it should not be done because of the risk of COVID-19 infection. Unfortunately, the virus has been detected in stool. Now, doing a digital rectal examination won't add or take much from this patient. Basically, you want to feel the prostate, as maybe it could be one of the reasons for his hematuria, or to complete your urological examination. But no, it's not very much indicated here, and try to avoid it as much as possible. Well, until further instructions, because unfortunately, there are a lot of newly daily changes in the management of patients with COVID-19 and with urological presentation. So the next slide. Now, at this point, I'm going to pick your minds by asking these questions. At this point, what laboratory and or imaging investigation do you recommend to this patient, and why would you want these investigations? I'm going to just give it a minute, just 1 minute, to people to think it out. You don't need to write it في comments, just think out and formulate a plan. Right, so we will go to the next slide, and this patient طلبنا له um, uh, full blood count، طلبنا له kidney function test، طلبنا له coagulation profile, which I'm going to talk about in a minute. Why did we do that? طلبنا له formal urine microscopy and cultural sensitivity. We have a patient who have got a positive white cell in the urine dip and with mild fever, so it needs to be sent to microscopy and cultural sensitivity as well. والريزلت جاتنا كالتالي. So this patient, unfortunately, his kidneys took a hit from the clearly renal stone that he's having. أنا كتبت البارامترز أو الميجرز كلها whether American system ولا British system. احنا هنا في UK بنستعمل الملي مول بير لتر. انا عارف الامريكان سيستم بيستعملوا ملي جرام بير ديسيليتر. anyway to make things clear حتى بالنسبه للشباب سواء في السعوديه في امريكا في السودان او حتى هنا في UK انا كتبتهم كلهم. So اليوريا بتاعته was 12 which is definitely off the scale. الكرياتينين بتاعه 155. Always يا شباب لما يجيكم patient زي ده it is really good if you have a background you have a baseline to compare with. Now to make things easy for the presentation البيشنت ده ما عنده background او ما عندك baseline تقدر تحكم عليه اذا كان هو طلع كثير من البيزلاين بتاعه ولا لا. estimated GFR is 55. Unfortunately he was in AKI 1 which is acute kidney injury 1. البوتاسيوم بتاعه كان 3.8. الوايت سيل is 18. البليتلت is 290 which is fine لكن clearly عنده leukocytosis. liver function test was within normal limits. Coagulation profile was within normal limits. Urine microscopy and cultural sensitivity were pending. لسه results ما جات. Now let's analyze this. So initially we said in our differential diagnosis that this is a renal colic patient. Clearly his kidneys are under pressure because of this. Creatinine 155 is abnormal or 8.6 milligram whatever you want to relate to. He's in AKI stage 1 or class 1 acute kidney injury 1 because of the biochemical disturbance اللي حصل في الكدني function بتاعه. His potassium is absolutely fine. I've got a white cell count of 18. So we're dealing with an impending septic patient of a white cell 18, low grade fever, renal colic patient. Now, if we are dealing with an obstructed infected urinary system, this is the ultimate urological emergency. This is a top emergency that needs to be dealt with promptly and correctly to avoid catastrophe. Such patients can die in a blink of an eye. They can go down the hill very easily. And they will be 1 hour ago they are talking to you fine, and next hour they are in the ITU and they are intubated because they tend to go into sepsis really fast. So that's not the kind of patient that you would put in the bottom of your list. That's someone you really need to take care of. Now to answer the second question, which radiological investigation we are going to request, the best radiological investigation is a CT KUB, or CT kidney ureter and bladder, non-contrast. ليه CT scan? Studies have shown that the specificity of CT scan is 97% with the sensitivity ranging between 94 up to 100%. It is fast, it can be done in few minutes. It has a very high level of specificity and sensitivity, meaning it gives you an accurate positive result, and it takes away any false negative results as well. Ultrasound scan, it can be used, it is still being used. لا غضاضة, لكن you need to know a sensitivity بتاعت ultrasound scan in detecting renal stone is as low as 60%. Now in the في EUA, European Urological Association, it is still in their guidance and you can use an ultrasound, especially with special condition patients like pregnant ladies, for example. حتى لو ما ورتك الستون at least it can tell you if the system is under pressure ولا لا، الكدني دي is swollen up ولا blown up because of backflow of urine ولا لا. So this is one benefit of it. MRI urography is overly sensitive. It is really good. Sometimes we need to use it with pregnant ladies because ultrasound scan ما ورتنا حاجة and patient is still in pain. لكن طبعا ال MRI عنده a very يعني عنده a lot of limitations. A cost is one of them. It's only in centers where they do MRI routinely وكتير جدا to the point where the cost of MRI بقت بالنسبة للسنتر ده which is very limited number of centers بيعملوا الكلام ده is equal to the cost of a CT scan. ساعتها ممكن تطلب MRI لكن usually no, it's not even in the guidance يعني. And the other thing is you need to bear in mind إنه not everyone is happy to go into a tunnel for like 40 minutes يعني. People tend to be claustrophobic, why to go through all this hassle while a CT scan can help with this. In patient above 50 years old, with the lack of availability of CT scan, ultrasound scan can be requested, and the aim here is not just to detect renal stones, the aim is to rule out conditions like leaking AAA. So basically you are excluding other pathologies by requesting an ultrasound scan when you don't have facility of a CT scan. Next. Now here we are going to show an image of a CT scan. I will move the mouse into the image and it will show, I hope واضحة عندكم. Clearly on the left hand side you can see that the pelvis is dilated over here, especially when you compare it to the normal renal pelvis. Here a system is blown up. You can see calyces here are dilated. And on the as we go down in our slides we can see here في الimage on the right hand side the reason for the for this is a stone. So this is definitely a renal colic patient, and this is definitely the diagnosis of the patient. Now again, does this exclude the fact that the patient could be having COVID-19 on top of that? No, it does not, of course, unless you do a CT chest, that's something else. لكن the sections اللي usually بناخدها من a CT scan for the kidney, it includes only the bases of the lungs. It doesn't go beyond that. Now we move to managing this patient, and in managing a kidney patient, our renal, now we know that we have an obstructed, infected system. This is a top urological emergency. هنا بتحضرني قصة لطيفة حكاها لي بروفيسور كنت شغال معاه في السعودية. early القصة ديت يعني قال لي early 90s يعني لما قال لي بيجي أنا consultant يعني. مرة ضربوا لي بالليل وقالوا لي في بيشنت ممرضة هي في الحقيقة في المستشفى عندها رينال كوليك، وعملوا لها سي تي سكان لقوا عندها 7 ملم ستون وبسبركتنج الكدني بتاعها. عمرها كم؟ قال عمرها 34 سنة. فقال لي يعني كانت الساعة 3 صباحا، وقمت قلت لهم خلاص ادوها انتي بايوتكس وادوها بين كيلرز لحد الصباح انا بجي ونشوف لها مانجمنت يعني. ما I don't think انه دي حاجة top emergency. قال لي I will never forget البيشنت دي and it changed the way I practice medicine. أنا بحكي لك القصة دي قال لي so that أنت برضو to be aware of it. بالليل ذاك البيشنت دي she deteriorated, she went into septic shock, she went to the ITU, she was intubated, and she ended up with low urine output. At this time someone tried to challenge her kidneys by giving her mega doses of furosemide. Unfortunately her kidneys were knocked off and she developed a very uncommon side effect to the very high doses of furosemide. She became permanently deaf unfortunately. الصباح لما جاء يشوفها قال لي مشيت، قالوا ما فيش في الطوارئ، سألت منها قالوا في الاي تي يو. مشيت برضو كنت مؤمل انه بس تكون يعني جاتها فيفر وشوية low blood pressure, that's why she's over there. Unfortunately مشيت لقيتها intubated and next day they started dialysis. She recovered after 2 weeks من الانسيدنت دي and unfortunately she recovered deaf and I will never forget البيشنت دي. So I'm just bringing this on to know how serious a septic infected system can be. So لما نجي للمانجمنت back to the slides, we can classify them into acute management and definitive management to this patient. So in acute management, we manage the patient as sepsis management. Now our patient, alhamdulillah, is clearly he's maintaining blood pressure, clearly have got an acceptable pulse rate, things are more or less under control for him. If you suspect sepsis at any point, we initiate what's known as sepsis 6, and for people to remember them easily, sepsis 6 is formed of giving 3 to the patient and taking 3 from the patient. So you give oxygen supply with the aim of maintaining oxygen saturation above 94%, and you give antibiotics as well according to the local antimicrobial guideline. بيختلف من مكان لمكان، فبالتالي I can't recommend حاجة specifically. الحاجة الثالثة that you give is fluids to maintain circulatory support in case of your patient is impending shock. الثلاثة حاجات اللي بتاخدهم من البيشنت، بتاخد bloods for cultural sensitivity and for lactate، and الحاجة الأخيرة بيقول لك بتاخد urine, which means إنه you put a catheter and you measure the urine output. So this is sepsis 6. This definitely will keep your patient more or less in the safe side. Any deterioration, now you can at this point escalate to a higher level of care like ITU or HDU. Pain control. Now there is always the discussion whether should we give a renal colic patient non-steroidal anti-inflammatories or opioids. So this discussion has been finalized قبل موضوع COVID-19 ده، بأنه non-steroidal anti-inflammatories have been known to be superior to opioids in dealing with renal colic patients. طبعا specifically in our patient, البيشنت في الكيس ديت, we are not keen on giving him non-steroidal anti-inflammatories because of his raised kidney function test. So opioids is going to be the other option for this patient. Now, from the beginning of the COVID-19 pandemic, people are talking whether non-steroidal anti-inflammatory drugs are safe for patients with suspected COVID-19 or no. Last month كان عندنا meeting في المستشفى، كانت pulmonologist عملت لنا orientation يعني, and she said that there is no evidence to say that non-steroidals should not be given to patients with COVID-19, but people are talking about that they may have increased risk of upper GI bleeding if it was caused by non-steroidal anti-inflammatory drugs. Now, same like few other things with COVID-19, still there is a lot of uncertainty. I personally would go with paracetamol. I will follow a WHO ladder of pain control. If the patient needs non-steroidal with an acceptable kidney function, no history of allergies or asthmatic, for example, I would happily give it to him. Otherwise, you can always offer him opioids, and it should also tackle the problem. Now, there is always an infinite questions in urology whether should the patient receive fluid therapy or not. Now, our patient is not septic, so we do not need fluid to support the circulation. We need, some people say that giving fluids or instructing patient to drink a lot of fluid is going to help pushing the stone down. Unfortunately, this has no evidence to support it whatsoever. It's just a fashion that people would hook up a bag of fluid for a patient with a renal colic لأن هم محتاجين fluids. Maybe in this condition, in this patient specifically, because of his kidney function, you would want to hydrate the patient more. But you need to bear in mind that the reason for his raised renal function test is not poor kidney perfusion. It's actually post-renal, it's obstructive uropathy that is causing what is it causing. Now, if you want to argue that I am giving fluids because of a low EGFR or a raised creatinine, you can win this argument. But again, bear in mind that it's not going to help him with passing the stone. Now, when we go to definitive management, this patient needs his system to be unblocked, to be unobstructed, and this can happen by inserting a double J stent under local anesthetic if the patient is systemically unwell, and it is a very doable procedure. Bear in mind that do not delay management of a patient because it only needs to be under general anesthetics. Now, I know زملائنا الانesthetist are not going to be very much happy with anesthetizing a patient that whom he is already having his blood pressure in his boots زي ما هم بيقولوا. Otherwise our patient specifically I think he is fit for a general anesthetics. ما في مشكلة. الفيلير rate بتاع inserting a double J stent can be up to 15%. So these up to 15% أو من البداية أنت if you feel a patient that is not suitable or not fit for general anesthesia and you are not happy or comfortable in putting a stent under local anesthetic, then nephrostomy tube inserted with the help of intervention radiologist is your next step of management. هنا بنرجع للinvestigations مرة ثانية. That's why I requested the coagulation profile. Now you do not want to be chasing your tail while your patient is crashing. Meaning ما ممكن أنت you failed inserting a stent and you want a nephrostomy tube, which you should be talking to your intervention radiologist right now. هيسألك what is the PTT INR of this patient. ممكن at this point you start sending bloods now. No, you will want to be ready with your bloods. My PT is so, my APTT is so, my INR is كده. If he needs reversal for whatever agent he's on, you should be able to do that. Your platelet count is fine. He is going to be very happy to do it for you. Finally is the definitive treatment, which is طبعا primary URS ureteroscope. Primary URS, the BAUS مرة ثانية, British Urological Association surgeon, recommends that it should happen in about within 72 hours of the onset of the symptoms or presentation to A&E. Now I know إنه ده كلام قد يكون حالم شوية نوعا ما، لأنه حتى في الميتنج بتاع السنة اللي فاتت في جلاسكو لما اتقال الكلام ديت most of الحاضرين قالوا it doesn't happen because of many logistics. Number one, اليوريتروسكوب نفسها is not something that is available in the middle of the night بسهولة unless you are in a really specialized stone dealing center. Number two is the laser machine that you are going to use for fragmenting that stone. أنت محتاج laser certificate. الستاف اللي معك محتاجين laser certificate. You need to do it in a laser in a theater with laser capacity. Now نرجع تاني للكوفيد 19. This patient زي ما تفضل او امبارح زميلنا احمد مأمون السيت اب بتاع الثياتر اللي هيتعامل فيه in spite of it is emergency it needs to be the same way described by احمد مأمون في البرزنتيشن بتاعه. It was very nice, very thorough. I liked البلوبرنت اللي هو خدتها. ممكن ترجعوا لها في اليوتيوب channel تشوفها مرة ثانية upon how to handle this patient. آيات ذكرت البوينت حقت donning and doffing. برضو you need to have this in mind and you need to be vigilant about it. So other treatment methods, we can do watchful waiting for stones which are up to 6 millimeters in a non-septic patient with normal kidney function and pain has been managed. يعني في a lot of conditions you can decide to بعدها leave the patient to go for watchful waiting. Such stone can pass up to 90% within 6 weeks. So up to 6 weeks. عشان كده we prefer انك ما تدي البيشنت appointment to the clinic in less than 6 weeks. يفضل اكتر من كده عشان نشوف اذا كان البيشنت managed to pass the stone ولا لا. ESWL extracorporeal shockwave lithotripsy is always an option. عنده criteria معينة وعنده indications و contra indications ممكن نتكلم عنها في وقت تاني في محاضرة تانية. ما عايز اطول اكتر من كده. Finally في حاجة اسمها medical expulsive therapy, and medical expulsive therapy is just simply alpha blockers. It was until 2015 thought to be very effective in helping the patient expelling the lower ureteric stones, and it was thought to be helping patient in about 29% in lower ureteric stones, and this is documented in the European, American Urology Association as well. In 2015 a large randomized control trial called the SUSPEND trial showed that there is no benefit of medical expulsive therapy, and the last guidelines from the BAUS suggest or states clearly that the medical expulsive therapy can be offered to a patient. مش should be offered. It can be offered provided in you're going to counsel the patient well about the side effect of the medicine and the expected benefit من المedicine نفسه. And the reason they allowed this to be used is simply well, point is valid to be honest. يعني لما سمعت أنا anything that can help the patient حتى لو بنسبة 1 or 2% is going to save him from having surgery under general anesthetic. So I would go with it as long as it does not going to harm, or it's not going to harm the patient. يعني. Next slide. Now I think I can conclude my presentation at the next slide about what message to take home from this case. And number one is consider high index of suspicion for COVID-19 when dealing with a febrile renal colic presentation patient. Avoid digital rectal examination as COVID-19 virus was detected in stool. Consider all measures of precaution when operating on a COVID-19 positive patient. And finally, always remember that an obstructed infected system is an emergency that needs to be dealt with promptly. Next slide is going to be about the references. هتلقوها موجودة إن شاء الله في presentation, which I'm going to make sure it's إن شاء الله تكون available to everyone. إذا ما داير تمشي بكتب كثيرة, الويب سايت بتاع BAUS British Urological Association Surgeon and European Urology Association is very thorough and very updated. ممكن تطلع بنتائج كويسة جدا. I'm happy to take your questions في comments and I will answer them إن شاء الله كلهم. أتمنى إنه البرزنتيشن ده أضاف لكم معلومة جديدة أو عمل ريفرشمنت لحاجة جديدة. Thank you so much للناس اللي حضروا. I appreciate it. You can disseminate المعلومة. إن شاء الله ربنا يقدرنا ويقدركم على إنه المعلومة تصل ناس كثيرين ويستفيدوا منها ونقدر نقدم حاجة للوطن. Finally, أحمد مأمون الله يديه العافية إن شاء الله حيحرص إنه المحاضرة تكون أو البرزنتيشن يكون موجود في اليوتيوب شانل. ممكن ترجعوا عليها في أي وقت. الشخص ما أتيحت له فرصة الليلة أو حب يرجع لها تاني في أي وقت, ما في أي مشكلة. ختاما شكرا لكم مرة تانية. أنا وائل جعفر, الدفعة الثانية جامعة الرباط الوطني, ومرة تانية بقولها بكل فخر, أنا وائل جعفر جامعة الرباط الوطني. في أمان الله.